Welcome to The Backstory with Dr. Ricky Singh. This podcast is focused on bringing you the latest research-based information about dramatically improving health, well-being, and quality of life. And here's your host, Dr. Ricky Singh.
Today I want to talk about a topic that perhaps does not get much attention, probably the attention that it deserves. And joining me today is an expert in the field of addiction psychiatry, which, from what I found in my research, is a relatively new and emerging field. And we're going to explore the stigma associated with substance use and substance abuse, and perhaps how we can change the way we talk about this condition. And I also want to touch briefly on how the COVID pandemic has played a role in substance use, and more specifically, alcohol consumption. So today's guest is an associate professor of clinical psychiatry at Weill Cornell Medicine and New-York-Presbyterian Hospital. So I'm very excited to have this talk with Dr. Jonathan Avery. Dr. Avery, welcome to The Backstory.
Thanks so much for having me. It's a wonderful podcast, and I'm happy to talk about addiction.
Well, I appreciate it. So, the field of addiction psychiatry, and, admittedly, I didn't get much exposure to this in my training, and perhaps nowadays they do. So what is addiction psychiatry? How did you get interested in this? And tell me about your expertise in the area.
I never thought I would be an addiction psychiatrist, to tell you the truth. I grew up, my dad's a hospice physician, and, I always thought I'd be taking care of geriatric patients or doing some other specialty. But during medical school, I trained at NYU, I saw that there were so many patients struggling with substance use disorders. And I also saw that pretty much no one wanted to take care of these folks. And, sort of how my dad always said for his hospice patients that, not many people are comfortable dealing with folks at the end of life. I realized, hey, some of these skills I learned in that space, talking to people about death, about topics that seem, taboo, so to speak, are the same skills I can use to talk to folks with substance use disorders, talk to their families who are struggling, and then talk to the medical community. And so a lot of my effort has been understanding why we don't talk about it more and what stigma exists towards substance use. And that's why I'm always excited to be on podcasts like this and to talk about it wherever I can.
Right now we're in the COVID-19 pandemic, and that's certainly the hot topic, and we're all struggling to get through it. There's light at the end of the tunnel. I'm optimistic. But a few years ago, another epidemic was plaguing our society, one that's specific to my specialty, of the opioid crisis. And I feel like we could have done a better job as healthcare providers in treating those patients and conditions. So tell me about, how does what you studied and your research kind of impact what we could have done with the opioid crisis from a few years ago?
Right. And I'd say the opioid crisis is still going on, maybe even worse during COVID-19. It's still many lives lost each year. And I think as much, we've done so the opioid epidemic in some ways started from doctors overprescribing opioids, and then, we cut down on the prescribing and people turned to heroin. And now we're in sort of the third wave of the opiate epidemic, where fentanyl is contaminating pretty much anything that doesn't come from the pharmacies. So it's not only people misusing their pain medications, but sort of really powerful opiates showing up in all substances of abuse. And people are really losing their lives. And I think the reason we still haven't been able to address it as a medical community or as a society, and why the deaths are still high, is related to stigma, is that basically, we can say it's a problem and we want to put money towards it, but I'm not sure there's the clinicians and the society that wants to sort of rally around these folks with substance use disorder. And my research has shown that our attitudes as doctors, as clinicians, are worse towards folks with opioid use disorder and addiction than towards any other medical or psychiatric condition.
In medical school, we're taught about alcoholism, and we learn that alcoholism is a disease. It is a condition. There is neurobiology behind it. It's part of a brain disease. Yet, you're right, healthcare providers, and I might be guilty of this also, we have this negative stigma associated with substance use. When I look at a patient and their past medical history says substance use disorder, immediately I know what things maybe I should not prescribe. Maybe something addictive, like a muscle relaxer or an opioid or a benzo, something like that. And yet I don't really go deeper than that. I kind of leave it alone, and I say, let me focus on what I need to focus on, and kind of leave that alone. How have what you've been working on changed that behavior in healthcare providers to really attack the addiction use disorder?
Right. Well, our goal is really to make every doctor an addiction doctor, to make it something that everyone feels comfortable addressing and talking about, from just sort of asking the questions and understanding what one's substance use disorder is to actually, prescribing things that can help with it. I think with the opiate epidemic, historically we would say if someone's struggling with substance use, just go to AA. I think what the opiate epidemic did, especially with the doctors overprescribing opiates, is that it encouraged all of us to really take ownership of a patient's substance use disorder, see how we can help them with meds in the office, with referrals to therapy, or whatever else may be going on. And I think to the degree we can do that, our patients can have the best outcomes.
We get a lot of referrals for patients thinking that we're a pain clinic. We have a multidisciplinary spine center here, but inevitably you're going to see a patient that's taking high-dose opioids or high-dose narcotics. And as part of Weill Cornell's mission of wellness, and we have an opioid task force, we want to minimize the number of patients that we have getting these medications. So rather than bringing them all in and trying to taper them and give them other strategies, the immediate knee-jerk reaction is, let me refer you to a pain clinic. Let me refer you to a chronic pain center. Is that the right way to do things, or could we do things a little bit better internally?
I mean, in an ideal world, we would have these collaborative care models where addiction psychiatrists would exist alongside pain specialists, would exist alongside you guys or pediatricians or whatever other specialty there is. And unfortunately, around the country, there's just so few addiction providers. And then increasingly, the pain folks don't want to prescribe opiates and are doing interventional stuff. And so there's this whole concept of abandonment going on right now where all these folks with high-dose opiates sort of have nowhere to go. It's hard to get into addiction care. It's hard to get into pain care. And, our goal as we combat the opiate epidemic is really to equip all providers with the ability to prescribe things like buprenorphine, which is the medication that helps opioid use disorder, to do other interventions that might help.
I love that one thing you said. You said there needs to be a culture shift where all doctors are addiction doctors, and you mentioned that earlier. I had a very interesting conversation with Dr. Saeed Ibrahim. We just wrapped up Diversity Week here at Weill Cornell, and, we talked about diversity, inclusion, social justice. Obviously society is recognizing the inequities in racism and sexism and other discriminations. But I feel like, the individuals with substance use disorders also get discriminated upon. Why is this, and what can we do to kind of change that narrative?
That's the hardest thing to combat, and we've been trying for decades and been pretty unsuccessful. I think the reason there is such stigma is there's still the view that it's a moral failing as opposed to a disease, that it's sort of bad people doing bad things, as opposed to sick people who are, acting in a way in service of their neural pathways being hijacked by a difficult process. And so, one of my favorite sayings in recovery is that we're not bad people becoming good, but sick people becoming well. And that's the spirit we should address these folks. However, the stigma is there on so many layers of society. We learned early on that we should punish these folks, kick them out of school, send them to jail. It's associated with the same issues of race and other biases. Often these folks have co-occurring mental illness, which comes with its own stigma. And so there are all of these factors that push addiction to the secrets, that say to families, don't talk about it, that tell healthcare providers, this isn't in my specialty. And at the end, it's a whole bunch of folks not getting the treatment that they need and being ignored, and addiction really grows in the secrets, and that's where we've pushed it.
You write about a skill called motivational interviewing. Tell me about motivational interviewing. How do you implement the strategy, and what can we do, maybe apply it broadly across medicine in general?
Right. And we're teaching this to families, to everyone these days. Historically, you go see a doctor and you're struggling with addiction, and the doctor's an incredible finger wagger. Don't do this. What are you doing? You're gonna die from this. It's hurting your liver, your kidneys, your brain. That's not a very effective way to engage with folks. It pushes people away. And so what motivational interviewing teaches you is to meet people where they're at, to roll with resistance, to see what they like and don't like about the substance use, and to just meet them wherever they are in their health timeline, knowing you're not likely to have an aha moment in this setting, but really creating the space that allows them to change and allows the change to come from them. And that's why I don't get burned out working with folks with substance use disorder, because I don't view myself as any sort of savior who's got to save the right thing and come in and intervene, but I'm someone meeting someone where they are with their disease, and we're in it together, and we'll see what we can do.
I love that you talk about burnout too. As a spine doc and pain management doc, yes, I get frustrated when patients don't get better. And I take that personally. I take that on the interventions and the tools and the treatments that I've prescribed. They're not working for this individual, and I get frustrated, maybe at me, maybe at the patient. You're not doing what I told you to do. I told you to lose weight. I told you to stop smoking. I told you to exercise. And, what you're saying is compelling to me. Maybe I need to kind of take a step back. Instead of that finger wagging, come and see them. Why haven't you been able to do some of the strategies that I've prescribed to you? When it comes to addiction, what are some of those things? How do you, for someone who doesn't use substances, how do you meet them in the middle?
Well, I think use always starts for a reason, and we talk a lot about the self-medication hypothesis of substance use, and people are tolerating what it does to them because of what it does for them. And so if we can understand the whys, either from a mental health perspective or a pain perspective or whatever it is, that'll give us an insight into what interventions we can do to help them. And change is the hardest thing any of us do. I can't get to the gym before work. I would have loved to come before, but I just couldn't do it. And imagine struggling with a substance use it so hijacks one's brain. And so, I think if we can understand the why, we can target interventions. We can get them to mental health providers. We can think of other interventions for their pain. We can connect them with communities and resources, and they do exist.
When we talk about this as a disease, as a condition, I just want to go over some definitions. Substance use, substance abuse, substance misuse. What are the correct words that we should kind of use when we address patients?
And so addiction is tied up in all this problematic language that contributes to the stigma that exists, and referring to people as addicts or talking about clean and dirty, or there's a lot of punishment and failure built in with the language. And so the current way we describe addiction is with the term substance use disorder. So an alcohol use disorder, an opioid use disorder, and then we separate the person from the disease. So we say he's an individual with an opioid use disorder, with an alcohol use disorder, with the marijuana use disorder. And in that way, it sort of recognizes that there's an individual there, and it's not just a heroin addict or a drug addict or any of these terms that sort of dismiss people when you label them that way.
You mentioned, marijuana. Previously, at least my limited understanding was you couldn't really get addicted to marijuana. Marijuana wasn't something you could get abuse or misuse. And now with New York City legalizing recreational marijuana and decriminalizing it, I should say, have you seen that increase, or are you seeing that more in the patients that you're treating?
I haven't. The problem with the way marijuana has been punished or legislated is that it ends up with a lot of people with low-level drug offenses in jails. And the worry with the legalization is that this will allow more people access to it, especially adolescents, potentially higher potency versions of it. But I'm not for putting people in jail and punishing for their addiction. At the same time, with the legal status, we do have to make people aware that it is still addictive. And, it's not the same risk as alcohol use disorder, alcohol necessarily. And, something between 9 to 20% of people who use marijuana will end up with a marijuana use disorder. And so a lot of people will use it and not get addicted. But there will be a subset, especially if use goes up, that will become addicted and will need treatment.
We talk about the COVID pandemic. We're still in it. And you've done some research on how this pandemic has increased substance consumption, particularly alcohol consumption. Tell me a little bit about what your study and what your research has found and what steps you guys are taking to minimize.
Sure. Well, COVID-19 presents all the risk factors for getting into trouble with addiction: isolation, financial stress, work stress, taking care of kids at home. All this stuff is very stressful, and we know that. And so it's not surprising that people have turned to substances, especially because they couldn't turn to anything else. You can't go to the gym. You can't take walks outside practically. And so, the easiest way to escape and provide relief sometimes for a lot of folks is substances. And so in the community, we're seeing use go up of opiates, and the opiate overdose crisis increasing, and then a ton more people using alcohol. Sales are up 15 to 20%, depending on where you look, and it's impacting everyone. I think the most notable statistic is that the drinking patterns of women are way up. And what we've noticed in the hospital and some of the research we've done characterizing the way people have presented to the hospital during this pandemic is we've seen more and more young women coming in with liver failure with really severe consequences of their alcohol use. And these are mothers, stuck at home and drinking to deal with a ton of stress. And it's not the cohort we were seeing before COVID-19.
Let's talk about that a little bit. People's relationship with substances, particularly alcohol. Some may say I have a casual relationship. I'm a social drinker. I drink only on the weekends with friends. Some are more, committed to this relationship of alcohol use disorder. How has, you mentioned social isolation, staying at home, certainly not working or working from home, all those increases stresses, increased anxiety, maybe increased depression. How does that translate into alcohol use?
Right. I mean, as I said, those are sort of the risk factors for getting into trouble, and it's a sneaky substance, right? I mean, if you look at the media or talk to anyone, it's sort of the answer to every question in our society, right? It's what you do when you're stressed, what you do when you're celebrating, what you do when you break up with someone, and it's such a part of the culture that it's not surprising from the Zoom drinking parties to all the other ways it quickly got integrated into Zoom and COVID culture that we want to keep the drinking alive and it's okay to drink more. And that sort of viewpoint that it's okay or an expected response is what's gotten people into trouble for decades and certainly has gotten more and more into trouble during COVID-19. And it's very slippery between being a casual one drink a night person to really starting to have to increase as tolerance builds, as stress and mental health issues build, and then you end up in trouble before you know it.
I mean, I'm not sitting here on a clean slate either. I've had a rough day at work or the kids stress me out and I say, man, I need a drink. Is that the wrong way to think about things? Is there a better strategy than needing that drink when I'm down or needing a drink when I'm really, really happy? Because that's how I like to drink.
For people that are trying to moderate or be mindful of their drinking, we do have them pay attention to sort of that, self-medication drinking. And that's where you get it. That's where it gets a little risky, to tell you the truth. And it's when you're sort of saying, I'm stressed, I need it, or especially if you're using it for sleep or for antidote to depression or anxiety. That's a slippery slope because you're going to need more. The tolerance is going to build. Kids are going to be annoying for the next 2 decades, and so eventually we'll have to figure out other tools in order to not get in trouble, I think.
So you're the founder of the Weill Cornell Medicine New York-Presbyterian program for substance use and stigma of addiction. I know you've been doing a lot of outreach in educating people like me about the stigma of substance use. Tell me a little bit about this program and tell me a little bit about some of the outreach things that you've done.
Right, and I think we have to tackle addiction as a community, and so the spirit of this program is that we're bringing the community into the hospital is going out into the community, we're all having conversations like you and I are having today about addiction and substance use, and so from going into schools to talk about the youth vaping epidemic to giving out naloxone rescue kits and other things that can help you if you're getting into trouble with opioids, to talking about drinking wherever they'll have us. We're out in the community, sort of addressing substance use, encouraging families to talk about it. They're actually recommending now that you start talking to your kids about addiction at age 9. And that's the same thing we're recommending on the doctor end of things, that we should be asking all our patients about substance use, that we should all view ourselves as addiction doctors, as I talked about before. And to help doctors understand it, our program brings in a lot of people in recovery into the medical setting so doctors can see the people that get better. We're also bringing families that have lost loved ones to the opiate epidemic or have seen loved ones struggle with addiction to talk to doctors about what that experience is like and what they would like to see in their clinicians. And we've developed a bunch of online modules that highlight those things as well.
Let's talk a little bit about recovery. Have you seen patients or a majority of people recover from substance use disorder? What do the stats say about that?
Yeah, I mean, there's 24 million people in recovery in the United States. The odds are for anyone that comes into our hospital struggling with opiates that they'll be in recovery one day. But unfortunately, most clinicians never get to interact with those folks, which is partly why the stigma is high among doctors, is that once they're in recovery, it's a note in their chart and not your active experience of them. So your average clinician is really only having an active experience with people who are actively using, and they don't sometimes get those wins to see people in recovery. And I often have to tell my trainees that some of my most rewarding work is seeing people in recovery, seeing them have kids and get their lives back on track. And, that's why we bring in the people from the community in recovery, so that we can see folks who are better, who are living their lives, and we can carry those narratives with us to our patients.
Can you share one of those patient stories that kind of really stuck with you during your training and maybe motivated you to pursue this field in addiction psychiatry?
Sure. I mean, one of my favorite patients is a guy I've been seeing since my fellowship, around 7 to 8 years now. He was a quote-unquote frequent flyer. In medicine, we call those folks that are constantly in and out of the emergency room. He was drinking a lot. He was using other substances, getting into legal trouble. He was a sort of patient who clinicians would say there's no hope for him. He had the experience of being neglected at times in the emergency room, being punished by society, by his job. And we got him on a treatment that involved his whole family, especially his dad, who had struggled for substance use early on. And now, 7 to 8 years later, he's married. He's about to have his second kid. He's doing well. He comes sometimes and speaks with me at different events to tell his story. just because he didn't have the hope for himself, clinicians didn't have that hope for him, and now to be in this spot where life is so rewarding, brings him such joy, and it brings me joy to think about it. And he's the person I often think about as I interact with patients who are feeling hopeless, or who are other folks are feeling hopeless about.
No, I can see your face light up when you speak about him, because certainly that's a very passionate story, and I think it's important. You're right. If we as healthcare providers see light at the end of the tunnel and hope for these patients, I think we will kind of change the way we approach them and give them the tools necessary to get their lives back and on the road to recovery.
Hope is out there. People can change. There's a lot of people that can help you get there too. And so, the other thing about doctors or people in the community is that, doctors are more at risk for substance use than their age-matched peers. And, doctors especially hide their own substance use. And so part of our efforts are also addressing it in our own hospital system, to finding safe spots where doctors can think about their own use. And that's the spirit for society in whole. We want pilots, we want lawyers, we want Wall Street guys to feel like they have a safe spot. I mean, I sometimes laugh at some of these interventions that folks are doing during COVID with the Peloton bikes and the other things to improve wellness. People need addiction care. They need some treatment. They need someone to go to and talk to and to address the mental health. There's only so far Peloton bikes, I think, will take us.
You mentioned exercise and how that's good for the mental health. Obviously, we've studied that in our spine center. And also the genetic components. In back pain, we know that there is a genetic component of getting degenerative disc disease based on genetics. Is the same true for a substance use disorder? Is there a family history?
Yeah, a lot of the risk for substance use is related to genetics. And we think about half the risk is genetic, about half the risk environmental. There's a lot of genes that have been described that are involved in both addiction, but also in mental illness. It seems the same genes can lead to both, and that makes sense. And it's often co-occurring disorder with mental illness and substance use. And so that's also a reason to not feel stigmatized or not to blame yourself when you get it. There's certain folks who just, when they have a drink, it lights up their brain like it doesn't for other folks. And we know that if you have less of an enzyme that metabolizes alcohol, for example, you don't get in trouble as much because you have a negative experience when you drink. But there's certain folks who can drink a lot. It lights up their brain in ways it doesn't for other folks. And especially if they're struggling with mental illness, it's really hard to stop the behavior.
Is there any pharmacotherapy to give patients to have that negative experience, albeit not naturally, but next time they drink, they remember that this was not fun, so I'm not going to do this again?
Right, and that's a big change in medicine, is that we're increasingly giving medications to help folks with substance use disorders. There's a lot of great psychosocial treatments, the 12-step works, the AA, the AA alternatives that exist, the outpatient rehabs and therapies. But the real sea change in addiction over the last 10 years has been us prescribing medications to help. For folks with opioid use disorder, you pretty much have to be on meds if you want best outcomes. And for alcohol use disorder, there's a menu of medications, some that can help you drink less even if you're drinking, like naltrexone. And then there's a medication called Antabuse that if you take it, you become very ill on it. And so you don't drink if you have that on board. And actually, the guy I talked about earlier, he did something that's called the Antabuse contract in order to become sober, which is with his dad at the beginning of his recovery. Every day he would take Antabuse, which is, again, the pill you drink on. If you take, and if you drink on it, you become ill. And he would do this ritual with his dad where he would say, "I agree not to drink today, I'll take Antabuse." And the dad would say, "Thank you for doing that, we're in it together." And his dad also used it for his recovery. And then now 7 years later, about to have his second child, he still does that with his wife every morning. He says every morning, "I agree not to drink today, I'll take my Antabuse." And his wife says, "Thanks for doing that, we're in this together." And that highlights for him his sobriety, but it also provides him this real barrier from drinking, because he knows if he drinks, he could become very ill.
Now, I love that story. I think, like you said, it takes a village, especially for substance use. Even for my world of spine pain and back pain, I think we could do a lot together. So what can we do? What can we do with our multidisciplinary spine and pain center, with all the work that you're doing? How can we make Weill Cornell really a center of excellence for patients with addiction use?
Well, the good news is we're starting an addiction fellowship this summer. We'll have a couple of fellows, and we're increasingly growing as an addiction department. And you guys are obviously a world-class department. And so as hopefully more people go into addiction, as our service grows, and we can sort of combine forces, I think, that we can be seeing the same patients, that we can be thinking together about non-punitive policies that, get people into treatment I think sometimes what happens is that when someone is using substances, it's a reason to discharge people, and whereas I'm arguing it's a reason to get closer to people. And if we have an integrative model, if you and I combine forces, we can really get close to people and help them really address their pain and substance use in a way that I think is lacking around the country.
No, I mean, having this conversation with you is making me rethink how we write up our opioid contract. And we have a contract with patients, but you're right, it's punitive. It's not really helpful. Patients lose their prescription twice, or they take their meds too fast, and our immediate knee-jerk reaction is discharge. And I'm feeling guilty about the way I've treated those patients.
Oh, no, then I failed a little bit, because my job's not to be figure-wagging. I mean, the hard part is to sort of give this message that I'm passionate about in that motivational interviewing way, because we're so... It's not you, it's not the department, it's just all of medicine is set up in a way that isn't quite welcoming towards folks with substance use disorders, and so to think about how to do that is hard, and we're so specialized these days that it's hard to get sort of a team together, and people really need teams if they're really struggling, if they have severe pain, if they're needing interventions and mental health and substance use. It's hard for any one provider is the truth, and so as much as we can have an integrative collaborative model, I think we can do our patients well.
I'm very optimistic. I'm looking forward to the next iteration of our multidisciplinary spine and pain clinic. Working alongside you and your team is really going to improve the outcomes of our patients, so I really appreciate that. As the vaccines are being rolled out, and patients, especially in New York, people are getting excited about the summer of New York and going out and interacting with the community again. Share with our listeners a little bit about some advice on how to be mindful when it comes to alcohol use or even substance use, how to be thoughtful on not to cross that line into a slippery slope.
Right. And for drinking, we have numbers that we sometimes have people pay attention to, which I think are helpful to track if you're trying to moderate your drinking, which is, for men, no more than 3 drinks on a given day, for a woman, no more than 1 to 2 drinks. And then weekly, for women, no more than 7 drinks, men, no more than 14. And that's taking days off in between and not building the tolerance. That being said, someone could drink less and still end up in trouble, or someone could drink more and not be in trouble. But those are sort of guideposts to help us, to keep things in a moderate path. And that can be helpful. But I would say for any other substance, be it weed or alcohol, anytime you're slipping into the self-medication, and the self-medication is slippery, like it is also for anxiety, depression, but it's also self-medicating the good times, Sometimes we feel like we have to drink in a way to enjoy ourselves, or to, go out and party, or to have sex, or whatever it may be, and that's a slippery slope as well, because then you don't learn that you can do this on your own. And so I think as we get out there in the world, as our menu of options expands, we should try to do more and more of those without substances and get the natural rewards that life can bring us.
I certainly appreciate that. I used to have the saying of, drink to make yourself happier, not drink to make yourself happy. But based on what you're saying is maybe that's not an ideal strategy either, because that's medicating to promote my jubilation. I know, what a joy kill I am today. But it's finding the balance. It's trying to be moderate and also not to, if one night goes too far, to, pull yourself together and regroup the next one, and not be punishing to yourself along the way either, because this has been a hard year, and we all have to be forgiving to ourselves and to each other, because this has been a lot. Dr. Avery, thank you for sharing your insight on the topic of addiction and substance use, substance misuse, but mostly really speaking to me on how to talk about addiction with our patients and perhaps remove some of the stigma associated with the disease. I'm encouraged by the way you motivationally interview people, and I think that can be applicable even in our own relationships with our spouses, with our kids. So I'm going to take some of those skills back. And thank you out there to the listeners tuning into the backstory. Take care of yourselves, take care of each other. Be mindful when it comes to alcohol and substance use, especially this summer. And remember, when it comes to your health and wellness, we've got your back. Thank you.
Thanks for listening to The Backstory. Please subscribe, rate the podcast, and review The Backstory on Apple Podcast, Spotify, and Google Play Music. And feel free to share this podcast on social media or even your own website or blog. This podcast is for general information purposes only. It does not constitute the practice of medicine, including the giving of medical advice. No doctor-patient relationship is formed. The use of this information is at the user's own risk. The content of this podcast is not intended to be a substitute for medical advice. To learn more about Dr. Singh and his clinical research, please follow him on social media. You can also sign up for his newsletter by going to www.rickysinghmd.com. That's RICKYSINGHMD.com.